So I would be presenting this topic on behalf of Dr. Tamilarasi. My sincere apologies. So this is IOL power calculation in pediatric population and how to go about in a traumatic cataract. So pediatric traumatic cataract, we are posed with a lot of problems because it is not just like an adult injury, and open globe injuries are more common than closed globe. An initial evaluation, like all the speakers have mentioned, is very important. A posterior segment thorough evaluation to rule out any posterior segment significant pathology should be done at the initial visit itself as far as possible. And why is it so difficult to manage traumatic cataract in a pediatric age group? It is because there are a lot of changes in axial length and keratometry, especially that happens in the first 2 years of life. And children are quite uncooperative, especially when they undergo a trauma. There could be a lot of stress. The parents will be stressed. And different biometry and anatomical differences from adults are there, and we need to use adult formulas, and we'll have to adjust for the pediatric population. And cataract surgery itself is slightly different, and the effective lens power might change a little bit according to the lens placement. And target refraction is another problem that we face in the pediatric population. So it is just not we just calculate the power and put it, we have to anticipate a lot of things to take care of the growth. So axial length in the pediatric population, it increases more in the first 2 years of life, more so in the first 6 months. And immersion is better than contact biometry, but in most cases we may not be able to do so. And if needed, we need to do a general anesthesia before the surgical management. In traumatic cataracts, that also may not be possible. So an initial globe repair with a secondary IOL implantation might be considered. An optical biometry should be considered in any cooperative children, and if the injury is in such a way that we can do an optical biometry. This is a handheld keratometry done to get the keratometry readings of a small child. And this handheld keratometry can be done under anesthesia, or if the child is cooperative enough, without anesthesia. And keratometry in corneal tear, what are the points that we should take into consideration? We may not be able to take a correct keratometry reading in a corneal tear child, so we may need to take it from the contralateral eye. And the corneal curvature is slightly steeper in children, so it might be difficult to take a standard K. So we may need to calculate the other eye K reading and take it. IOL calculation formulas. This again is not same as in adults. The infant FAK treatment studies have shown that Holiday 1 and SRK-T give the minimum possible errors, but we generally use Barrett's Universal 2, which has given promising results. And we need to have a caution in children less than 2 years, age less than 9, axial length less than 19 millimeters, and a steep K. And in less than 2 years, we need to think a lot before placing an intraocular lens, because we have to take into consideration a lot of things. And less than 1 year, it would be judicious, if it's a traumatic cataract, to go in for a secondary intraocular lens if all situations are not favorable. And what about the target refraction? The eye is growing, so we can't put a lens and just forget it. So we need to calculate for the growth of the eye and the myopic shift. So what sort of target refraction do we do for pediatric cataracts? It's similar to the target refraction that we aim for in developmental cataracts. In general rule is 20% in less than 2 years and 10% in 2 to 5 years, but we need to tailor make each IOL power in each child. It might be different. Sometimes the axial length might be different. It may be the child might show a higher axial length or a shorter axial length. So we need to calculate for undercorrection basically, since we should expect a myopic shift. More than 6 to 8 years, we need not undercorrect. We can put the calculated intraocular lens power. So the factors affecting the time of traumatic cataract extraction: if there is a severely compromised anterior capsule and an intumescent lens, we need to do a cataract lens aspiration at the time of corneal tear repair, whereas we will wait maybe a few weeks before we plan for a secondary intraocular lens. So this is a video showing the traumatic corneal tear repair with a ruptured anterior lens capsule. The lens aspiration is done, followed by a posterior capsulorhexis, and this should be considered in every child less than 7 or 8 years of age, because the chances of posterior capsular opacification is great. But however, we need to tailor make our decision, because there might be some cases in which the posterior capsule might be compromised, or the zonules are compromised, in which we go with a different decision. So IOL in a traumatic cataract, which type of lens do you implant? We generally go with a single piece or a multi-piece acrylic intraocular lens in most of the cases. And in some cases, when there is compromised bag or a posterior capsule, we might go in for a secondary intraocular lens implantation. So what is the problem in putting a lens in the sulcus if there is a compromised posterior capsule? We need to take care of the anterior optic capture, which is very common in children in sulcus placed lenses. We can prevent this with a primary posterior capsular rhexis with a posterior optic capture in the posterior capsular rhexis. Or this is a technique which is described by Dr. Ken Nischel, the banded technique, in which the band which is formed in the anterior capsule, that is left behind, and this acts as a support to prevent lens iris contact. So that is another thing. And in some cases in which the anterior capsule is intact but the posterior capsule has ruptured, we can do a capture in the anterior capsule as well. Open globe injuries with compromised bags, cortical matter in the vitreous, we might do a globe repair first and then go ahead with a secondary scleral fixated IOL according to the age of the child. So what happens when we cannot do an A scan? We can go with a technique which has been described, that is, do an aphakic refraction. And from the aphakic refraction, we can do a vertex adjustment and calculate the K. From the K reading, we can adjust the focal, from the focal length, we can calculate this. And from that, we can calculate the IOL power in the formula by dividing it with the refractive index. We get a rough axial length, and from that we can do that. So this is another technique which has been described, which can be done. Regarding multifocal IOLs or premier IOLs in pediatric cataract surgery, we need to evaluate the pros and cons. The advantages of multifocal and toric and all are that it has rapid visual rehabilitation and eliminates the need for glasses. But we need to weigh something which is high in vogue in this age group, because the IOL power calculation challenges are there. A proper centration cannot be ensured. Reduced contrast and photic symptoms will result in amblyopia. So we might have to go for a single piece intraocular lenses in most cases, but suppose the visual axis is clear, there is no corneal injury, it's just a blunt injury. In such cases, if we get a proper calculation, we might go in for a toric or a multifocal intraocular lens. So we need to custom make all these things for pediatric traumatic cataracts. Thank you. So I'll be continuing with wrapping up this with the next talk, Dr. Lakshmi.
Dr. Lakshmi will continue with post-ocular trauma follow-up in a child.
So this is just to sum up what we have learned now. We have a lot of terminology systems in trauma. We have the Birmingham eye trauma terminology system, as well as the ocular trauma score. And as Dr. Soumya has already mentioned, the ocular trauma score is a better indicator of outcome, especially in pediatric cases. So why do we need the scoring system? It's mainly for prognosticating these cases, and from a medico-legal perspective, it is mandatory that we score these and document these properly. So the problem with pediatric age group is again the young age, poor visual acuity assessment in the initial phase, and due to poor cooperation. Sometimes we may be able to assess many things when the child is under anesthesia, when we are giving anesthesia for repair. So we might need to score the child according to the examination findings on anesthesia. So documentation is always very, very important in a trauma case. Visual acuity assessment, we need to do some form of visual acuity assessment in the pediatric age group, either a simple fixation following or a Cambridge vision or a Leah symbol. most of the LCD screens that come with visual acuity have the Leah symbol. So, in possible cases, we need to record visual acuity. It gives a lot of information. Corneal injuries, the importance of refraction cannot be stressed more. Most often, we just repair the corneal wound and the follow up may be irregular. We need to counsel the parents that the follow up is very important. And in most cases, if it might be a small corneal injury which is away from the visual axis, but still it can induce astigmatism in a growing child. And if this astigmatism is not given and if amblyopia treatment is not initiated, this will not give you a very good outcome. So, we need to do a refraction in the postoperative period while the child comes for follow up, and we need to initiate occlusion therapy or any form of treatment for amblyopia as the age permits. Ocular surface management in chemical injuries is also important because that also might result in a very poor outcome even though the initial phase is very well managed. Aphakic rehabilitation with occlusion therapy, like already mentioned, we might go in for a primary intraocular lens or a secondary intraocular lens according to the prevailing situations. This is of utmost importance, and if you are leaving a child aphakic, immediate before discharge, it is better to give the child an aphakic glasses for rehabilitation. But unilateral trauma cases, it might be different. In select cases, we might go in for a contact lens, extended wear contact lens, but that needs a lot of expertise. So, at least a aphakic glass during the times of occlusion therapy can be initiated in the immediate post trauma period. Glaucoma, Indian studies have shown that it's approximately 20%. And when should we suspect glaucoma in pediatric ocular trauma? When there is a lens injury, anterior segment inflammation, hyphema, zone 2 injuries, penetrating injuries, angle recession, firecracker injuries, all these conditions we should anticipate glaucoma and evaluate for it. Hyphema, even after resolution, we need to look for rebleed. That is a common cause for glaucoma. IOP more than 21 might need treatment, and they need a lifelong treatment follow up. Retinal detachment, a thorough posterior segment evaluation is mandatory in almost every post trauma follow up visit, or at least a yearly after the child has become stable, because we might miss on peripheral retinal changes following the trauma, and this needs an indirect ophthalmoscopy, and the importance of this cannot be stressed more. Whenever required, don't hesitate for an examination under anesthesia or a mild sedation with a pedicloral in required cases, because if we omit this, this might even cause the vision of the child. So, an examination under anesthesia for any retinal changes, if we suspect them, should be done, and this might save the vision of the child. So, never hesitate if required, but otherwise, try to do everything without an anesthesia. So that is to sum up about the important points in trauma in pediatric. So thank you for your patient listening, and thank you all the panel members and the speakers and the audience for your patient listening.